Welcome back to the deep dive. Today we're tackling a topic that might seem niche, but is definitely high yield for MSRA revision: keloid scars. We've got the essential info lined up for you.
That's right. The idea here is to really distill the key facts, take all this revision material and give you a clear, efficient overview, exactly what you need for the exam.
Perfect. Okay, let's unpack this then. What exactly is a keloid scar? How is it different from, just a normal scar healing up?
Right. So at its most basic, a keloid is an abnormal type of scar. It's raised, yeah, and thickened. But the really defining thing is that it grows beyond the edge of the original wound.
Ah, okay, so it doesn't just fill the gap, it actually expands outwards into the healthy skin around it, like it doesn't know when to stop.
Exactly. That's a great way to put it. It's excessive scar tissue growth that just keeps going. They feel quite firm, rubbery sometimes, and can get significantly larger than the injury that caused them.
What about how they look?
Well, the color can vary. They might be red or pink, especially when they're newer or actively growing, or sometimes darker than the surrounding skin. But importantly, they are benign, not cancerous, and definitely not contagious. It's an individual's healing response gone a bit wrong.
Got it. So it's like a benign overgrowth, almost tumor-like in its expansion beyond the original site.
Precisely. The descriptions often mention them extending well beyond the wound margins.
Okay, that brings us to the really interesting part. Why? Why does this happen? What's going on underneath?
It's complex, as you might expect. Fundamentally, it seems to be an inherited, abnormal response to skin injury. There's dysfunction in how the body controls certain things,
Right.
like growth factor activity in the extracellular matrix.
Growth factors,
Yeah.
like the signals telling cells what to do.
Exactly. And there are abnormalities in collagen turnover. Collagen is the protein that makes up scar tissue, right? In keloids, there's just way too much collagen being produced and laid down during the healing process.
Mm.
The stop signals seem to be faulty.
So the body just keeps building and building scar tissue.
Pretty much. There's an imbalance involving key signaling molecules. One that often comes up is transforming growth factor beta, TGF carry. When that pathway is dysregulated in someone who's predisposed, you get this characteristic overgrowth. And genetics play a massive role. We know this. Genome-wide studies, GWS, have actually pinpointed common genetic risk factors, particularly noted in, for example, Chinese Han and Japanese populations.
So a definite genetic link.
Absolutely. And hormonal factors seem involved too. Keloids can sometimes appear or get worse during puberty or pregnancy, suggesting hormones influence that abnormal healing process as well.
Okay, if genetics and hormones are factors, who is actually more likely to develop these? What are the key risk factors we need to know?
Right, let's talk risk factors and epidemiology. A big one is family history. If you have close relatives with keloids, your risk is significantly higher.
Makes sense with the genetic link.
Yeah. Exactly. Ethnicity is also very important. Individuals of African, Hispanic, or Asian descent have a much higher prevalence. Age is another factor. They're most common in the 10 to 30 age group, peaking around 20 to 30 years old. You don't see them much in the very young or the elderly.
What else?
Having a previous keloid makes you more likely to get another one. Darker skin tones are often cited as a risk factor, though, interestingly, some of the material notes that the evidence for this link might be weaker than traditionally thought. It's a nuance worth noting for revision.
And location matters too, right? You mentioned earlobes.
Yes, definitely. Keloid-prone areas include the earlobes, piercings are a common trigger, the chest, shoulders, upper back, and the sternum. Areas with more skin tension seem particularly susceptible. Also, wounds that take longer to heal or have more tension across them are riskier.
So looking at the bigger picture, epidemiology-wise,
Prevalence varies a lot by ethnicity, as we said, higher in those with darker skin generally. Common in young adults, rare at extremes of age. Affects both sexes, maybe slightly more females, according to some sources, others say equal. And that family history link is strong. About half of people with keloids have a family history.
okay, let's try a quick MSRA-style vignette. Imagine this. A 28-year-old man of African descent comes in. He's got this itchy, raised lesion on his shoulder. It started after a boil healed there maybe 6 months back, and he's sure it's grown bigger than the original boil spot. He also mentions his dad gets bad scars. Based purely on that, what factors strongly point towards a keloid?
Okay, great case. Let's tick them off. His age, 28, right in that peak bracket. His ethnicity, African descent. The location, shoulder, a classic site. The trigger, inflammation from a boil. The key observation, growing beyond the original boundary. The symptom, itchiness. And finally, that positive family history. All those together make keloid the top diagnosis.
Spot on. Okay, so moving to the examination, what are the specific things you'd actually see and feel?
Clinically, they are visibly raised, yeah. And they feel firm, sometimes described as rubbery. The surface is often smooth, maybe a bit shiny. Crucially, you'll see it extending beyond where the original injury was, sometimes with a slightly overhanging edge.
And the color.
It can be pink or red initially, especially if growing, or darker than the surrounding skin. Over time, some might fade a bit, but they rarely match the normal skin tone perfectly. Symptoms are important too. Itching or pruritus is really common. Tenderness or even pain can occur, especially during active growth phases. Patients might describe a tingling sensation.
Can they cause other problems?
Yes, if they form over a joint like an elbow or knee, they can actually restrict movement, functionally limiting. And you won't find things like hair follicles or sweat glands within the keloid tissue itself. Common sites again. Earlobes, chest, shoulders, upper back, sternum, sometimes cheeks.
What's their natural course? Do they ever just go away?
Generally, no. They tend to persist for years. They might grow slowly for weeks or months, potentially even years, then stabilize. Sometimes a very slight regression might happen, but they don't typically resolve spontaneously. But remember, they are benign. No systemic symptoms.
And you said diagnosis is usually clinical. No need for biopsies usually.
That's generally true. Diagnosis is based on the history, the risk factors we discussed, and the classic appearance on examination. A biopsy isn't routine. It's reserved for cases where you're just not sure, or if you suspect something else might be going on, like ruling out a malignancy, although that's rare.
Which brings us nicely to, well, what else could it be? What are the main differential diagnoses?
The number one differential, the one you absolutely must be able to distinguish, is hypertrophic scar. This is key for exams.
Okay, how do we tell them apart reliably?
Hypertrophic scars are also raised and can be red and itchy, but, and this is the crucial difference, they stay within the boundaries of the original wound. They do not invade the surrounding normal skin.
Right. So I like that visual. Keloid keeps going beyond its bounds while hypertrophic H stays high but within its habitat.
That's a perfect mnemonic. Exactly. K for keloid, reaching beyond. H for hypertrophic, staying high but homed within the original injury. Also, hypertrophic scars tend to appear sooner after injury, maybe within weeks, and they often regress or flatten somewhat over time, which keloids usually don't.
Okay, that distinction is clear. Are there other less common things?
Yes, other possibilities exist, though they're less frequent differentials. Things like dermatofibromas, which are common benign skin lumps. More rarely, you might need to consider something like dermatofibrosarcoma protuberans, which is a low-grade skin cancer, or certain inflammatory conditions like keloidal granulomas. This really underscores why a biopsy might occasionally be needed to rule out these other conditions if the picture isn't typical. Let's test that distinction again. A patient presents with a scar on their forearm from a burn 3 weeks ago. It's raised, red, a bit itchy, but when you look closely, it stops exactly where the burn ended. They think maybe it's getting a little less red now. What's the most likely diagnosis? A, keloid, B, hypertrophic scar, C, dermatofibroma, D, squamous cell carcinoma.
Okay, key points. 3 weeks onset, within the burn boundary, maybe improving, sounds like.
Exactly. B, hypertrophic scar. The early onset, staying within the borders, and the potential for some regression all point strongly away from keloid and towards hypertrophic scar.
Got it. So investigations, mainly clinical, biopsy only if unsure or suspicious.
Spot on. Diagnosis is primarily clinical. History, examination. Biopsy is the exception, not the rule, mostly used to exclude other diagnoses when things don't quite fit the classic keloid picture. It just involves taking a small skin sample for microscopic analysis.
Right. So we know what it is, why it happens, who gets it, what it looks like, and what it isn't. Now, the big question, how do we actually manage these things? It sounds challenging.
It is challenging. Management often requires patience and multiple approaches. The main goals are really twofold: improve the scar's appearance and reduce symptoms like that troublesome itching or pain. There isn't one single magic bullet, unfortunately. Treatment options include topical things like silicone gel sheeting or silicone gel applied directly. These can help soften and flatten the scar over time.
Silicone, like you put on other scars.
Yes, it's thought to work by hydrating the scar and maybe modulating growth factors. Then there are injections into the lesion intralesional corticosteroids, typically triamcinolone. This is often a first-line treatment, especially for smaller or earlier keloids, aiming to reduce inflammation and halt growth.
Does freezing them work?
Cryotherapy, using liquid nitrogen, is another option. It can be effective. Sometimes it's combined with steroid injections. Pressure dressings or garments can also be used, especially after surgery or on earlobes.
What about more advanced stuff? Lasers, surgery.
Laser therapy is used, although the evidence is still a bit limited and more research is needed on which types are best. Surgical excision, cutting the keloid out, is an option, but, and this is a huge but, surgery alone has a very high risk of recurrence. The keloid often grows back, sometimes even larger than before.
Oh, wow. So cutting it out isn't a simple fix at all.
Definitely not on its own. That's why surgery is almost always combined with other therapies. For instance, you might excise the keloid and then follow up immediately with corticosteroid injections into the site, or start pressure therapy, or sometimes even use post-operative radiotherapy.
Radiotherapy, is that safe?
It's used in some specialist centers, particularly for resistant keloids after surgery. The doses are typically low, and while there are theoretical risks, studies suggest the risk is generally low, but it's usually reserved for difficult cases. Other treatments being explored for resistant keloids include injecting things like interferon or chemotherapeutic agents like 5-fluorouracil or bluomycin, or using retinoids. These are generally specialist treatments.
It sounds like combination therapy is really the key.
Absolutely. And multiple treatment sessions are almost always needed. It's usually managed by dermatologists or plastic surgeons.
Okay, what about prevention? If someone knows they're prone to keloids, can anything be done to stop them forming?
Yes, prevention is really important for high-risk individuals. The main thing is avoiding unnecessary skin trauma if possible. So thinking twice about elective piercings, tattoos, or cosmetic procedures in those keloid-prone areas like the chest or earlobes.
Makes sense.
Also, treating inflammatory skin conditions like acne promptly and effectively can reduce the risk of keloid formation from those lesions. If surgery is needed for another reason in a keloid-prone person, then meticulous surgical technique is vital. There's a suggestion to align incisions with skin tension lines, not necessarily the old Langer's lines, for potentially better outcomes.
And combining surgery with prevention.
Crucial. If surgery is unavoidable, combining it with preventive measures straight away is key, like starting pressure therapy or giving prophylactic steroid injections right after the procedure.
Let's lock that in with a final MSRA question. A patient, known keloid former, needs a benign mole removed from their upper back. To minimize recurrence risk, what's the best strategy according to what we've discussed? A, just excise it carefully. B, incise along Langer's lines precisely. C, combine the excision with, say, post-op steroid injections or pressure therapy. D, avoid all dressings to let air heal it.
Okay, thinking about that high recurrence with surgery alone, the clear answer is C. Combine surgery with other preventative treatments. Surgery alone is asking for trouble. Langer's lines aren't the main focus now, it's tension lines. And avoiding wound care is incorrect. Combination preventative therapy is the standard approach here.
Excellent. So looking ahead, what's the long-term picture? What's the prognosis for someone with keloids?
Well, keloids are typically chronic. They tend to stick around for years, potentially a lifetime. They're often difficult to get rid of completely, and recurrence after treatment is, unfortunately, common. The prognosis varies a lot depending on the scar's size, where it is, and importantly, how it responds to treatment.
Are there serious health complications?
Medically serious complications are rare. The main issues are cosmetic concerns, which can cause significant emotional distress, especially if the keloids are large or very visible. The symptoms of itching, pain, tenderness can really impact quality of life. And as we mentioned, if they're over a joint, they can restrict movement. There can also be complications from the treatments themselves, like skin thinning, atrophy, or changes in pigmentation from steroid injections, or recurrence after surgery.
Okay. So wrapping this up, we've gone deep into keloid scars definition, causes, risks, appearance, management, outlook, all distilled for revision.
Yeah, hopefully covering all those angles gives you a solid grasp. I think the key takeaway is that while keloids are benign, they represent this really complex challenge in wound healing. They significantly affect people's lives due to how they look, the symptoms they cause, and that persistent risk of coming back after treatment.
A really tricky area.
It is. And maybe a final thought to leave you with. Considering all the ongoing research into the mechanisms, like that TGF-β pathway, and the search for new therapies, how might future approaches shift? Could we move beyond just managing the symptoms in the scar itself, towards actually preventing the underlying abnormal healing response in people we know are susceptible? That's the ultimate goal, isn't it?
A fascinating thought. Well, that was a truly comprehensive deep dive into keloid scars. Definitely high-yield stuff.
Hope that structured breakdown helps it stick in your mind for the MSRA.
For more free MSRA revision resources, don't forget to visit freemsra.com. And for the full premium revision toolkit, you can head over to passthemsra.com. Thanks for joining us for this deep dive.